All right, so welcome. I'm Juan from City Ambulance, Regional Director for Central Texas. Today I have Morlines from coding. She's a specialist in coding, and we're going to discuss some common errors and how to correct them and how to get these reports processed, right? So a lot of the mistakes that are getting kicked back, it's really a request from the insurance, right? They want to see these things corrected. They want to process it. And in order for us to get it through insurance, we have to have these things corrected. Is that correct?
Correct. We want our documentation to support medical necessity, basically level of service, emergency versus non-emergency, and we want to meet compliance guidelines with the federal and state regulations.
A quick observation that I've seen, some of the most common mistakes, and you can correct me, emergent versus non-emergent. I've been a paramedic for a long time, and when I hear emergent, I only think of 911, lights and sirens, but that's not the case for billing, right? So emergent is anything that's not scheduled, right? So you can have like an appendix that bursts. That wasn't scheduled. It's not 911. You don't need lights, but it's, according to insurance, it's considered emergent, right?
Correct, because they're having an acute illness. So a lot of the hospital to hospital transports are not 911, but they are emergency because the patient has an acute illness, acute injury. Psych patients, they're having chest pain, cardiac, or anything that's going to be acute. So the patient cannot be treated at that facility. So the patient's going for a higher level of care. Something's not available at the pickup location, so they need to be transported. So that would be considered an emergency transport.
So anything going from one hospital to another hospital, higher level of care, even if it's a broken foot, is considered emergent, as opposed to someone going home or to a rehab center. That would be non-emergent, right?
Correct.
So another thing that I think a reason of kickback is LDTs. When you do an LDT, you're passing numerous hospitals, right? And insurance wants to know, why are we passing those hospitals? So how would you suggest we get that information, or what information do they want to see so that we can justify these LDTs?
Okay, so when we're reviewing LDTs, we want to know, is this the closest appropriate facility, or is it because the patient is returning to a hospital where maybe that's where they had surgery, or is it a request by the patient or the family? So it's not always going to be the closest facility, but we need that information documented in the narrative so we can build the insurance and let them know why we are going to why the patient was transported long distance transport.
Okay. And is that a justification if the patient just prefers to go to a farther hospital, or is that something that we probably have to bill the patient because the insurance won't pay?
Yeah, so depending on the insurance, some of them we do have to bill as non-covered mileage. So if it's not the closest facility, some of them we do have to bill as non-covered mileage.
So just on our part, we have to find out, why are we passing so many hospitals, and
Correct.
why are we going to that other hospital? And that would be enough in the narrative, right, to justify that?
Yes, correct. So it's either the closest facility for that specialty care, or the patient's returning to a preferred physician. Maybe that's where they got their surgery, where they received their transplant, or the patient requested or family requested to be transported to that hospital.
Okay. And then I think another big thing is justification from going from one hospital to another hospital, right? You're going from hospital A to hospital B. So you want to see, what is it that hospital A doesn't have the hospital B has, right? That's kind of like a CMS justification.
Yes, every hospital to hospital transport, we need to have the reason why they were transported. What was not available at the pickup location that is available at the destination.
And how vague can you be? Can you say, for example, okay, we're going there for a cardiac consult. Is that okay? Or a surgical consult is kind of that?
Yes. So when we do kick these back, it's when they say higher level of care. Well, what type of higher level of care?
Right.
Is it a pulmonologist, cardiologist? What type of specialty care does the patient require that's not available at the pickup location?
Yeah. And a surgery or even a consult would be justification, right?
Yes, as long as we know what type of specialty is not available.
Okay. And then once we have that, that's half of the battle, right? The next part is, why are they going via ambulance? So
Correct.
what's the justification? Because if you have a patient that's just like, for example, is going for a surgical consult and they go on the stretcher, is it because of weakness? Is it because of what? What would be the justification?
So the justification would be, what's the patient's condition? So are they having acute abdominal pain with that appendicitis? Are they having stroke-like symptoms, describing the strokes, right-sided weakness? It just depends on what the diagnosis from the originating hospital is. So if we are transporting, let's say for acute appendicitis, what are the patient complaints? What is their pain level? We need to know what the medical necessity is. So a lot of these, yes, the patient can walk to the stretcher, but the facility doesn't discharge the patient and say, hey, go to your physician. No, they want them to be monitored by trained EMT, paramedic, and because, it could endanger the patient's health, the
Got
patient's
it.
condition. The patient's condition can worsen. So that's why they require to be transported by ambulance service.
So that, yeah, that's a great point. That's a great answer. So I think so, like something like you mentioned, the abdominal pain, they may need a medication so that they don't vomit, right?
Correct.
They may need pain management. So
Mhm.
just justifying that you may have to do these things would be sufficient in this the narrative, right?
Correct. So if they have like an open IV, if it's a cardiac patient, do they need to monitor the patient, via ECG? So it really depends on the patient's condition and the diagnosis and why they require to be
Okay.
transported by ambulance and be monitored.
Okay. And then I have a lot of basics that tell me on discharges, they get reports kicked back because they don't know what to put for a patient that's going back home and needs a stretcher. Sometimes they put just general weakness. And is that enough to just put general weakness, or you want more
We
specifics?
want to know why the patient is weak. Is it because their history? Some of these patients, they have a history of CVA, so they have right-sided weakness, so they require to be moved by a stretcher. Um, Mobility issues. Do they have open wounds? Morbid obesity. Do they require O2? But the reason they require O2, do they have history of COPD and they require to be monitored from, the hospital to their residence or assisted living or nursing facility, skilled nursing facility. So we need to know what the patient's condition, why the patient couldn't go by other means that would not endanger the patient's health.
Great, great. Okay, so if you don't mind now, can we take a look at a report? I'll open up a report and we'll just start from scratch. And you can kind of point out some of the reasons things get kicked back. I know CMS level is a big thing. I know sometimes mismatch, right? We put something and then there's no match in the narrative showing that, oh, we actually did this assessment or we actually did this treatment. So stuff like that. Just, point out the most common mistakes that you see so we can hopefully prevent it in the future.
Okay.
Okay, so when a paramedic opens up the report, this is what they see. They get their incident numbers, and here there's usually no issues, right? We understand now emergent versus non-emergent, and you can be emergent and drive no lights and sirens, right? So you have to put emergent, like for the reasons that we discussed. And then scene, there's no issues with this. Personnel. Now, this is important, right? Because if it's a paramedic or a basic, let's say, and you gave an example of a report where a basic was the primary caregiver, but he did an ALS assessment, right?
Correct.
So that would be a mismatch and he would have to adjust that. There's no way he did an ALS assessment if he's a basic. So he would just have to put just a basic assessment, right?
Correct.
So destination, no issues here. And the times, do you ever have issues with times mismatching?
I haven't seen
Okay.
any.
Okay. And then the mileage is important also, right, for billing.
Correct.
Okay. Then we go through the patient information, their contact, putting their history, medications that they're on. Is a PCS required? So if we collect the PCS from the facility, it's a printed out paper. Do we still have to add to here, or do you guys fine with just a copy of the hospital's PCS form?
Yes, we're okay with the hospital PCS one.
Okay, so we'll do vitals, and we have to make sure that the patient at minimum gets 2 sets of vitals. If it's cardiac or emergent related, every 5 minutes, and non-emergent every 15 minutes. So if the patient goes cardiac arrest, any medications that we administered, we're going to note it here. And here we're going to add our protocols, what we actually did, what protocol we followed. And then here we have assessment. Okay, so narrative is the big one, right? This is where we get the most mistakes. So in the narrative here, we want to see, that's where you discussed, we want to see the justification for a patient going from one hospital to the other, a justification for the LDT, a justification for why is this patient weak? Is it history? Do they have sores? We just need more information here in the narrative, right?
Correct.
Okay, and then medical necessity, stretcher reason, that'll be kind of like what a summary of what we wrote in the narrative. So if we put this patient has sores, then stretcher reason, patient has sores or something like that.
Correct.
Okay. And then hospital reason, we have a bunch listed here. And then the attachments, of course, are important. I see a lot of kickbacks because of signatures, issues with signatures. What are some of the issues they have with signatures?
Okay, so if we didn't get a patient's signature and we did get an auth rep, we need to have the PUTS reason, like why the patient was unable to sign. Anytime that the patient cannot sign, we need to have the reason why patient couldn't sign.
Okay.
So it's okay if we don't have the patient signature, but if they don't sign, we need to have the reason why they couldn't sign. And I believe there's an area there where the medic fills out why the patient couldn't sign.
Okay. So if it's none of these, we can just put here other and then note it in narrative, right?
Correct.
Okay. But most of these kind of like summarize why the patient can't sign, right? If it's a minor and all that.
Yes.
So here, this is the billing section. We put down what kind of insurance, and again, the reason for PCS. If they went PCS meaning the patient went to a rehab center or went home, and they need the stretcher. What's the justification for the stretcher? And here, CMS level. This is important, right? If it's BLS or ALS1, ALS1 emergent, ALS2. What's the difference between ALS1 emergency, and level 2?
So ALS1 would be for ALS non-emergency transport. So let's say the patient's being discharged to another like rehab hospital, but they are a cardiac patient and they require ECG, but if they're going just for rehab, then that would be the ALS1 level 1, ALS level 1. The ALS1 emergency would be for the ALS emergency transport, like hospital to hospital. It's a patient that required ALS interventions. And then the ALS2 is the patient intubated, where was the patient given more than 3 IV medications by the medic. And then BLS basic, BLS emergency for emergent transport, no ALS interventions required. And then specialty care transport. So some of these patients that are intubated and have 3 IVs, and depending on what medication is running. So
So
Andre,
what?
y'all are having more specialty care, the CCT calls,
Yeah.
the patient with a balloon pump, that would be a specialty care transport.
Okay. All right. And then reason for medical transport. Again, here we're just putting the justification for the transport, right?
Correct.
What is the medical reason for transporting by ambulance? And that's again the justification for the patient either has an open IV and may need pain intervention, or they're unable to walk due to past stroke. That's what would be the reason for transportation by ambulance.
Correct.
So here on this example, again, you showed primary patient caregiver was an EMT, yet the patient here on the ALS assessment said yes. So this would be an issue. So insurance would kick this report back?
Yes.
Okay. So this is why when we see a report kickback, it's because of something like this. Like it can't be an ALS assessment if the basic was a primary caregiver, and the only thing that this basic has to do is just put no for ALS assessment, right? Do
Correct.
you have any more examples or anything?
Yes, I have a few. Okay, so this one is a non-emergency transport with conflicting documentation. So patient complaints, not applicable. It says primary symptom pain, injury of lower back, and then assessment, everything's normal. Pain level says 0. So the patient's being transported back to resident SP back pain. So on here, what is the medical necessity for this transport? If they're saying everything is normal and there's no pain. So why did this patient require to be transported by an ambulance?
So how would we approach a report like this? Like if the facility just tells us there's back pain and this patient's going back home, what do we need to find out on our end?
What the medical necessity is? I mean, does the patient have history of dementia? Does the patient can the patient not ambulate because of this pain? What the medical condition is when the patient is discharged. So when we're looking at these reports, we look at the dispatch notes also. And if it doesn't say wheelchair call, courtesy call, or patient needs a ride home, we're going with, okay, the facility dispatched an ambulance because the patient's condition, at the time of discharge, they require to be transported by ambulance, or it would endanger the patient's health.
Okay. So what if the patient had a surgery and they're recovering from the surgery and that's why they have back pain because of the surgery? What would be a would that be a
Yes,
justification?
I would, because they recently had back surgery, so that's why they still have pain at the time of transport. But this one, if they're saying everything is normal, um, when they assess the patient and then this it says zero pain, then what was the reason for this patient to go by ambulance? Okay, so this patient here, we have cough, respiratory disorder. So when the patient's going for a higher level of care, we want to know what the patient was diagnosed with at the facility. So when we open up the attachments and we also look at the dispatch log, it said the patient had RSV, bronchiolitis, but there's no mention in here in anywhere in the report.
Okay. So this report, they should have put specifics like the RSV, bronchiolitis, and
Mhm.
maybe they're going for a
Yeah,
pulmonologist.
and they did. We have the reason here.
Okay.
Okay, so we do have the HH reason. So we do
Okay.
have. But if an insurance requests these records, okay, the patient had cough, yes, they're going higher level of care. What did they get diagnosed with at the sending facility?
Got it. Got it.
So
So
all
the
the attachments have RSV, what the patient was diagnosed with, but there's no mention in the EPCR, you know,
So this would have not gotten kicked back if they simply would have just put that the patient was diagnosed with RSV at the sending facility or bronchiolitis at the sending facility.
correct. I believe QA goes through some of these. So we do have the medical necessity, but when they're documenting, and if we do need to provide the EPCR report to the insurance, we want to have the reason why the patient was transported. What diagnosis was the patient given at the sending facility? Okay, here is a discharge, and this one was kicked back. The narrative is one sentence long.
Generalized pain after post-op. So the patient had surgery
Correct.
and that's a justification, but there's just nothing else in the narrative.
Correct. How was the patient moved? Was it via lift assist? Was it
Yeah. Yeah, so this one actually does have the justification for the stretcher, right? I mean,
correct?
that one sentence is justification, but there's just nothing else in the narrative saying how the patient was found, mental status, how was the patient moved, vitals assessment, whatever. Nothing that a general narrative should have.
Correct.
Okay, yeah, I mean that makes sense why a report like that would be kicked back.
So for the intubated patients, sometimes we kick them back because it doesn't state what type of intubation for the patient.
Okay, so for the
Just
intubated patient, you want the whole thing, right? Like, what size tubing they were intubated with, when they were intubated, what medications were used to sedate them, how were they kept sedated, where is the tube at their teeth or lips, and when you get there in your assessment, is that tube still properly placed? How'd you confirm tube placement? Did you place the patient on the end tidal? Stuff like that.
correct.
Okay. Listening to lungs, right? You want to listen to lung. Do your own assessment as you transfer the patient to your stretcher, and continuing the assessment. And when you arrive at the facility, the tube is still at the proper place. All those things should be added in the narrative for an intubated patient.
Correct. Okay, so this one is a discharge and they're going back to residence. So the patient is nausea and vomiting, but that's what the patient was seen for at the ER.
Okay.
So when the patient is discharged, this is another example like the one that had back pain. What was the reason? And then they're stating that must be transferred to resident for specialist consultation for further treatment and ops. So this is kind of has conflicting information because patients
Yeah.
going to the resident. So how are they going for a specialist consultation?
Yeah. It's possible that the hospital recommended in the future they have to go for a specialist. But what you want to see in this narrative is what is the justification for the stretcher, right?
Correct.
Okay, so it's possible that this patient normally needs to get transported by stretcher, and we just need to put that reason why that patient gets transported by stretcher, right?
Correct.
So, okay, so we discussed a lot of errors. Can you show me a report where it's a good report, good information, they hit it, and it's a report that's not going to get kicked back?
Here is a discharge. Patients going from hospital to their residence. So this patient here, they stated the patient is bedbound. Sometimes we get reports that they just say bedbound, but they don't list the reason why. Here it is documented why the patient was bedbound. The,
Okay,
med-
so
the medical.
bedbound due to cerebral palsy.
Mhm. And they also listed the patient's history in there. So patient is developmentally impaired. So this does help. The history sometimes, because of the patient's history, sometimes this is why the patient requires an ambulance.
So that's what you're looking for. That this is a perfect report. The history matches the reason they can't go by wheelchair, and the narrative further provides information that shows why this patient can't go by wheelchair.
Correct. Okay, so patient, we have CMS levels, CMS service level, ALS1, ALS assessment, yes. Patient has abdominal pain. The narrative states what's not available, GI specialty, surgery due to bowel obstruction. So we have the reason why patient has the abdominal pain and the hospital to hospital reason, medic documented, EKG performed, and they also document what it read, AFib.
Good. Good.
So
So
the
everything here matches. It's an ALS assessment done by a paramedic, and the justification for the transportation from one hospital to the other is the GI specialist that's not available from the sending facility. So this is a perfect report, right?
correct.
Good.
Okay, so hospital to hospital reason. So this would be one that would be kicked back because it's just saying higher level of care.
Got it.
Okay. This one also because it doesn't state what the reason was for the hospital to hospital reason. What specialty was not available at the pickup location? So we have medical necessity, but we do need that reason why the patient's going from one facility to another. Also, higher level of.
Yeah. So we have to get away from that higher level of care and be more specific. What is the higher level of care specifically that's being offered?
Yes. And then long distance transports. So these are examples of where it was documented in the narrative why. So it's the closest accepting facility. So this
Okay.
one patient was transported to the closest pediatric facility, closest accepting facility because of the patient's history. And then here's an example of when the patient was transported for the preferred physician. So it could be the patient received surgery or a transplant and they're going back to that facility because only that facility can provide the patient care.
Yeah. And on this one, this is an example of the patient request, right? Patient transported over 126 miles due to the family.
Yes. So it could be either closest, preferred physician, or family choice. Sometimes
But
they put on their higher level of care, like long distance due to patient requiring higher level of care. Well, why was it 300 miles? Is it the closest accepting for that specialty? Here's another one with valid documentation, ALS1, ALS assessment. We have the complaint, symptoms, and then they documented what was not available,
pulmonology services.
patient's complaint, IV pump, patient placed on EKG. So the documentation does support that level of service.
Got it. So, like, since we put ALS1, level one, we want to justify what's the ALS1, and the patient being transported on an IV pump and ALS assessment does justify putting that ALS level one.
Correct.
So not only do we want to justify the hospital to the hospital reason, justify long distance if it's a long distance call, justify discharges that are going via stretcher. We also want to justify the CMS level that we put. So if we put ALS level one, ALS level two, specialty care, then in the narrative it has to support what we did to get that justification for that specialty care or ALS two, right?
Correct.
Okay, so final note, making sure that we justify everything that we put. It has to match in the narrative. So, for example, the coder gave examples of multiple reports where the hospital reason was only put higher level of care. Well, higher level of care is way too general. What was that higher level of care? Was it a GI specialist? Was it a surgical consult? So just specifying what that higher level of care, you want to justify why you're going from hospital A to hospital B. On long distance transports, you want to justify why are you passing up so many hospitals? Is there acceptance on that hospital? Is that why you picked? That's why the physician chose that hospital. That's the only hospital that was the closest hospital that was accepted. You have to put that in the narrative. Was it a patient choice? They want to be closer to home. You have to put that in the narrative. Then, if you put ALS assessment one, specialty care, whatever you're putting, you have to justify it in the narrative. So if it's ALS assessment one or ALS one, level one, well, you have this patient on a pump, you have this patient on a monitor. You did something that justified the ALS. Another example she gave of she showed a narrative with just one sentence. There has to be more information. How was the patient transferred to the stretcher? What kind of monitoring was done? Then, obviously, the justifications. All those things have to be put in the narrative. She gave an example also of the intubated patient with just one sentence saying that this patient's intubated, not showing the tube size, not showing the tube placement. Where is it at teeth? Where is it at the mouth? Why was this patient intubated? What sedatives, what paralytics were used to intubate this patient? What medications are used to continue to transport this patient on? When you assess this patient, how did you confirm tube placement? Did you listen to lungs? Did you place the patient on the end tidal? What medications were used to keep this patient sedated? You continually assess this patient. When you arrived on scene, you reassess the tube. It's still at the teeth, still at the lips, at whatever level. And this is for your protection. So just more detail. You can't just put this patient was intubated without putting all those other things. What are the vent settings? Did you have to adjust or titrate any medications or just a vent? All these things have to be noted in the narrative. You can't just put one sentence: patient intubated, patient placed on vent, transported. That's just not going to cut it. And it's also for your protection. A lot of the discharges are getting kicked back because people are just putting generalized weakness. Being more specific, what is it that caused this patient to go on a stretcher? Why did the facility call for a stretcher versus a wheelchair? There are times that a facility will call for a wheelchair, but if they call for a stretcher, there's a reason. Does the patient have a history? Is the patient in too much pain to sit in a wheelchair for long periods of time? Did the patient just have a surgery? Did the patient prior have a stroke and they have an unsteady gait and they're not able to sit for long periods of time? So you have to be specific so that these reports don't get kicked back. Also, mismatching information. So she gave the example of the EMT that put ALS assessment. So that's a mismatch. So making sure everything matches, your CMS level matches. If you put ALS assessment, ALS interventions, all these things, just making sure that it matches in the narrative what you did. Also with signatures, some of these reports, a simple kickback just because patient's unable to sign, which is fine, but you didn't put the reason why the patient's unable to sign. So all these little things will help reports not get kicked back and get pushed quickly. Thank you for watching.